the whole goal of the study was we wanted to get the women up to date with breast, colon, and cervical cancer screening. Never before had there been a study that focused on 3 behaviors at the same time.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Electra Paskett. Electra is the director of the Division of Cancer Prevention and Control, director of the Center for Cancer Prevention and Survivorship, and the founding director of the Center for Community Outreach and Engagement. Electra is one of the country's top epidemiologists, a visionary leader, and she and her team here at the James and Ohio State have created several statewide initiatives that have saved a lot of lives through education, prevention, screening, and vaccinations, and they have helped to reduce cancer health disparities throughout Ohio and beyond. In recognition of her amazing work over the years, Electra was recently awarded the Komen Award for Distinction in Population Sciences and the American Cancer Society's Professorship Award, which is the Society's most prestigious grant award. Congratulations on these awards and welcome back to the podcast, Electra.
Thank you very much, Steve. Happy to be here.
It's great to have you, and tell us a little bit about these 2 awards you've just received.
Right. So thank you very much for acknowledging them, and I'm very honored and humbled to have received them. The Komen Award is the Nancy Brinker Distinction for Population Science. It's only the second time that Population Science Award has been given, and it is given to a population scientist who has made a contribution in the area of breast cancer, screening, education, etc. And so I was nominated by the Ohio State Cancer Center and then selected by my peers.
We'll get into that specific program you did to help with breast cancer throughout the state, but that makes sense that the Komen Foundation organization is very interested in breast cancer, and you're a leader in that. And the American Cancer Society Professorship Award.
Right, and that also, I was so honored because I've sort of grown up in the American Cancer Society. They funded some of my early work and continue to fund me today in large research grants. And I've also served on grant review panels for them and other panels. I serve on several of the national roundtables, and just honored to be able to have one of these American Cancer Society professorships.
And it has a grant award, which is money that you can use for future programs.
It does. It is $400,000 over 5 years. So we're using it to do several things. So mainly, first of all, I've always wanted to create an association of Appalachian cancer centers. So these are cancer centers, both NCI designated and community cancer centers that work in Appalachian areas or have parts of Appalachia in their catchment areas. So we've identified about 18 or so cancer centers, and I've already talked to some folks, but we'll be reaching out and getting together with the goal of sharing best practices across Appalachia, what works, and would you like to adapt and implement this program, and then seeing if we can get some large research grants going together. So that's one of the projects I described. The other sort of focuses on more pragmatic trials. So pragmatic trials are real world examples of research. And so what I would like to do is be able to give our patients here at Ohio State University Wexner Medical Center the best advice gleaned from research to be able to do the behaviors, get the exams that they need to get, the vaccinations, so they can prevent cancer or detect it early. So for example, making sure that all the people who need colorectal cancer screening know that they need it, what tests they need, and make it easy for them to schedule. And what age to start. It's very confusing for colorectal cancer because there's so many different tests and different intervals that you can take the test. And most recently, the guidelines came down to age 45.
Right.
And even more recently, there was a new blood-based test that was approved by the FDA to be used for colon cancer. So it's a blood draw. And full disclosure, that is a Guardant Health test, and we received some small funding from Guardant Health to see if underserved and minority patients would accept that blood test. They asked us to participate in this study, and the answer is yes, people will accept the blood test. So I think it's going to change colon cancer screening.
Wow, that's new. I've not heard that before. I know the home stool test
Correct.
has been around for years.
Correct.
This is now a blood test.
Correct.
That you don't do it at home.
No.
You go to your primary care physician,
Correct.
your annual blood draw.
Correct.
And they can now screen for colon cancer in a
Correct.
blood draw.
Correct.
Wow.
Now, there's just a little difference with the blood test. It can detect early cancers. When you go and you do the stool-based test you're talking about, or you get a colonoscopy, those tests can detect precancerous adenomas.
Right.
But the blood-based test really was founded on detecting early-stage cancers.
The
So there's a
stool
little
test can detect precancerous polyps? I thought it
Yes.
was only cancer in the early stages. But
Both.
I could be.
Both.
Oh, okay. Oh,
So why?
Okay.
So why? Okay. So adenomas, just like cancers, are growths, right? So think of it as a little bubble, all right, off of the colon, right, which is like a tube. So when stool passes through, it hits that, and a little blood comes out.
Oh, so they're not. Okay.
So that's what they're detecting in the blood-based stool test or the stool DNA test. Some of the DNA of the adenoma or the cancer will slough off on the stool,
And that's how they
can
detect.
get it.
Okay.
Yeah.
That was great, but before we jump into some more of your amazing studies, there's a couple of terms we passed about: epidemiologists and cancer health disparities. So fill us in on what they mean and how that sort of drives what you do.
Right. So I'm an epidemiologist by training. Both my master's and my PhD are in epidemiology, and epidemiology is the study of epidemics. Cancer is an epidemic. So what epidemiologists do is study what causes different diseases. And so there are cancer epidemiologists, cardiovascular epidemiologists, infectious disease epidemiologists. Right. I call myself a behavioral epidemiologist because I use the principles and the study designs that I learned as an epidemiologist, and I apply them to designing and then testing behavioral interventions that get people to do the things that will prevent or detect cancer early, like get HPV vaccination, exercise, change their diet,
Stop smoking.
Stop smoking. Now, my friends are smokologists. I don't do the smoking. We have large studies where they're part of them, and they have their projects that are smoking cessation. But I
say that because I think that's the easiest thing for people to understand in epidemiology is that smoking causes lung cancer. Everyone can see that connection, but you take it to this causes colon cancer, this causes skin cancer, this causes cervical cancer, and you then create the programs that will reduce those.
Correct. So cervical cancer, we know over 95% of cervical cancers are caused by a virus, human papillomavirus. So if you get a vaccine that makes your body have the immune system in your body be able to recognize the virus and attack it and kill the virus, it can prevent cervical cancer and several other cancers.
Head and neck cancer.
Head and neck cancer, exactly. The other thing for cervical cancer is we know with cervical cancer screening, it can detect precancerous conditions that also, if you treat them, you can prevent cervical cancer, or it can detect early cervical cancers, which treated will prevent death.
So that sort of leads us into cancer health disparities, where people may not have the education or even the medical facilities around them to be able to do the things you just said.
Right. So disparities mean differences that should not exist. Okay, so I'm going to give you a blatant example that's not a disparity, right? There, you can say men have a greater chance of getting prostate cancer than women. Well, of course, because women don't have a prostate, right? That is not a disparity because that is explained by a biology. But among men, black men have higher rates of death from prostate cancer than white men. That is a disparity because there are differences that should not exist. Differences in death rates that should not exist.
So what are those differences that create that disparity?
So several years ago, we here at Ohio State were funded in an NIH initiative called the Centers for Population Health and Health Disparities. And we actually were funded on 2 rounds, so it existed here for 12 years. And in that initiative, the collective group from many institutions, we developed this multi-level model to explain disparities. And I like to think about it from the lung cancer perspective, all right? So most people say, well, you smoke, so you get lung cancer, right? Okay, I want to bring a little bigger thinking into our discussion here and how people think about this. We see differences in death rates from lung cancer in black men versus white men, okay? Why is it? Is it only because black men smoke? No. So this multi-level model has multiple levels. So we start at the bottom, which is biology.
Okay, that makes sense.
Is there something
different,
in different people that they have more predilection? They're more likely to be addicted to nicotine because we know nicotine is addictive. Are they more likely to favor menthol cigarettes? Yes. Okay. Okay, so menthol, there's something biology that can get you hooked besides the nicotine. Individual level is the next level up. Yes, smoking, okay? Now let's go one level up to social, the people you interact with every day. What if everybody you know smokes? It's extremely hard to stop smoking or not to start smoking if you have these cues all around you. And then let's go one level up to your workplace. Your workplace doesn't care if you take smoke breaks, right? They have an area easily that you can go and take a smoke break. One level up higher, the place where you seek medical care. You have a doctor that never asks you, do you smoke? Would you like to quit? Can I refer you? Never asks, right? And then let's go way up to the top level, which is policies. Let's say that you live in a state that's tobacco growing, that does not have a very high tobacco tax. Can you see how all of these multi-level factors will keep a person smoking and even prevents access to resources that can help them stop and perhaps now even screen for lung cancer and detect it early when it's treatable? That's what we're talking about when we say multi-level causes of disparities.
So that's the epidemiology part of it, analyzing in all this data. Then the behavioral epidemiology comes in where you create a program to
address every single one of those.
Okay.
Yes.
Which is what you've done for several different types of cancer.
Right.
So let's talk about a couple more of those. You already talked about one, but what's another one that you and your team have worked on?
So we have a statewide initiative, Turning the Page on Breast Cancer. And if people are interested, we have a website, breastcancerohio.org. And it on the website, as well as the entire initiative, is focused on multiple levels, being the woman herself and her family, the clinician or provider, the health system, and the health system. And on the website, there are tools for women to understand what breast cancer is, do a personalized risk assessment, and we give them feedback based on the questions, responses that they answer. And then based on the county they live in, they can go and see where they can actually get a mammogram if they don't know where to get a mammogram. There's resources for providers on there also. But for breast cancer screening, again, it's that multi-level. So at the bottom, we know that some women have genetic predilection to breast cancer, BRCA1, BRCA2, or something like that. So that's biology, right? The behavior is not only getting mammograms, but obesity, diet, exercise, things like breastfeeding has been found to prevent breast cancer. So that's at the behavior level. And
so do you mentioned the BRCA1 and 2, which is a genetic mutation that's passed down. Do you get family histories, and if someone seems to have a lot of breast cancer, you would then do a genetic test and they would know?
Right. So on that website, it talks a lot about family history. And several of the questions are about family history. And if there seems to be family history, then one of the recommendations is you should talk to your doctor about being referred for genetic counseling and genetic testing. Yes. And when we go to the health systems that are working with us, we do a presentation for their staff, and the first part of it is about genetic testing and genetic screening. Yes, very, very important. So that's the intervention that you can do at that biology level. And then mammography is something that we work with, on the individual behavior. The other thing is, a lot of times in a lot of communities, not only the minority community, but also the Appalachian community, we have found that people don't want to talk about cancer. Don't talk about cancer, because that is a death sentence. So why? Why do they get that perspective? Because everybody they know who's been diagnosed with cancer has died. So what we do is we try to then present role models of people who have lived after cancer because of early diagnosis, because of mammography. So if they have those role models, that eliminates some of that stigma there a little bit. And then we have some counties in our state that have no mammography facility. So what can you do for an intervention for that? We bring the James mobile mammograms, and we've been bringing the mobile mammograms specifically to 5 to 7 counties in Appalachian, Ohio that have no mammography facilities. We work closely with the health department, federal qualified health centers, the communities, and they ask us to come. They arrange for the women to be screened, and we come and we screen. So we bring the services there to them.
What's been the response? How?
Oh, great. We've been doing this for decades now. It's overwhelmingly positive response.
It seems to me, do you find that women who either didn't know about or were reluctant to get their first mammogram, once they go to the mobile mammogram, they come back every year, and it's like a relief almost?
We do. We have women who come back every year. Exactly.
Because they understand the importance of it.
They understand the importance, and my patient navigators work with them, and the staff at the Spielman Center are phenomenal. The staff that come on the mobile are phenomenal.
And so because you've been doing it so long with so many people, you've actually found women in the earliest stages of breast cancer that had great outcomes because of that.
We have. And then we make sure, because we have navigators there, we make sure that they get follow-up.
Just so people understand, a navigator is like a person who just calls and makes sure that person gets the next step of care.
A navigator is like your GPS through the healthcare system. Yeah. And whatever your issue is or your barrier to care, they help overcome that barrier for you. They'll get you a ride. And we do a lot of that, rides. And then, if there's an abnormal detected, we make sure that they get followed up locally, if possible. If they want to come here, fine. But if they can get their care locally, we facilitate that care locally. And then, so anyway, those are some of the things that we're doing along with the breast cancer screening.
So another one you touched on briefly was the cervical cancer program. You want to talk a little more about that?
Right. So when I first came to Ohio State in January of 2002, I saw on this data that was prepared by the National Cancer Institute that some of the highest death rates from cervical cancer in white women in the United States were in the Appalachian area of Ohio, Kentucky, West Virginia.
Well, wait, before you go, how did you find that? Were you just digging around, or you specifically said, I want to look at Appalachia and see what's going on? I mean, that's sort of a big thing to find that.
Well, the National Cancer Institute prepares these maps, so you can look and see where the hotspots are in the country. You can look for all cancers combined, new cancers called incidence, or deaths, which is called mortality.
So that information was out there, and you were decided it's time to do something about it.
Yeah. So then this call came out for these Centers for Population Health and Health Disparities. And so Dr. Mary Ellen Weavers and I wrote this large grant, and it had 3 components to it, 3 projects. One was increasing the uptake of cervical screening. One was smoking cessation, which Dr. Weavers led. And the third was looking at the prevalence of human papillomavirus in Appalachian women, because that had never been discovered. I mean, the prevalence had never been calculated. So at that time, we worked with Dr. Mac Ruffin. He was at University of Michigan at that time. So we did 3 studies. 2 were intervention. The first 2 were intervention, meaning we presented a behavioral intervention to get women to get Pap screening in Project 1, which was mine, or to get women who smoke to stop smoking in Project 2, which was Dr. Weavers. And then for Dr. Ruffin, he enrolled women who were coming into clinics. So we worked with about 18 primary care clinics in Appalachia, Ohio, and enrolled them in the study. They signed informed consent and filled out surveys, and we got cervical smears and some blood, and did looked at different outcomes. The main thing from that study was, for the first time, we determined the prevalence of high risk and any human papillomavirus infection in Appalachian women, and compared it to white women in the United States. And it was higher than in white women in the United States.
So if HPV was higher there, then cervical cancer would seem to be higher.
Correct. And that's one reason that there were higher cervical cancer rates. And then my intervention was using lay health advisors. So this was, think of a navigator, but based in the community. So we used lay health advisors, and we significantly increased the uptake of cervical screening. And then Dr. Weavers used the same lay health advisors, supervised by a local nurse, to deliver smoking cessation. And she significantly increased the proportion of women who stopped smoking. So from that, we were then able to submit a competitive renewal of the center, and we got funded a second time. This time we had 4 projects.
Ooh, okay.
And so, remember I told you that multi-level model from biology all the way up to policy? Right. So the project spanned across those multiple levels. So Dr. Chris Weghorst, he's retired now, but he was in the College of Public Health. He's a molecular biologist. So he wanted to look at the prevalence of a certain genetic mutation in cervical cases versus non-cases. And then we also did another smoking cessation study. But Dr. Weavers was interested in looking at, think of the multi-level model. Remember I told you social? Right. Yep.
So what's different socially there?
She wanted to look at, does it make a difference if people in your social network smoke? Are you more likely to be a smoker if your people in your social network smoke? Yes.
Yeah. That makes sense.
That's what she was looking at.
If they play people in your social network play basketball or knit, odds are you're gonna play basketball or knit.
Yep. And then Dr. Ruffin, he was very interested, I'm going to use a big word and then I'll break it down, in sort of the psychoneuroimmunology phenomenon, that where you live causes certain stressors in your life. You feel stress. that makes you sort of depressed, and that stress and that depression impact your immune system so that it revs up your immune system so that when HPV is introduced in your body, your immune system is so busy over here that it can't take care of the HPV in the virus here, and so the virus is then left to play and multiply and cause cervical cancer.
So what would cause this extra stress that would cause the immune system to ignore HPV?
All right, so where they live, okay, lower socioeconomic status, fewer jobs, right? So we did some key informant interviews, like we interviewed some women from Appalachia, and they said, well, it's just we're stressed all the time. Well, we don't understand what that word stress means. Can you tell us what you mean by stress? Sure. We don't have any jobs. There's no jobs. We don't have any money. So we don't have a car. We don't have a car. And even if we had a car, we couldn't afford gas. And even if we could get the gas for our car, there's no place to go. And we're stuck in our homes all day because of crime. And remember I told you this was a whole initiative, these centers? We had a sister center in Chicago, and they were looking at the problem of disparities in breast cancer death rates among black women. And they heard the exact same thing from the women on the south side of Chicago.
So inner city and rural Appalachia have the same, both cause stress for different reasons. The stress causes problems.
Underserved populations that experience disparities have some of the same external stressors. Crime, low socioeconomic status, which what my colleagues termed get under your skin, and they affect biological processes like the immune system. And how do you cope with stress that causes depression? How do you cope with depression? Well, what we found was that they would drink alcohol, smoke. Now, both of those, what do both of those do to the body? They cause more depression, right? They also negatively impact the immune system. And what's the third way they cope? Risky sexual behavior, which increases your exposure to HPV. Exactly. So can you see how this whole psychoneuroimmunology model worked?
It's a vicious cycle.
Yes. And so Dr. Ruffin was really worried that if these young women, these are young women we're talking about, experience this stress and this immune depression that I just described. If you give them the vaccine, would they still be able to mount an immune response to HPV?
Because their immune system is so stressed out, it may not take.
Yes.
Wow.
So that was his whole question. So in his project, he enrolled almost 400 women between 18 and 26. That was the age at that time to get the vaccine. You could go up to age 26.
Now you can go higher, but back then, lower.
Correct, okay. Correct. Back then, it went up to 26. So to participate in his study, again, the women were signed informed consent. They were fully informed of the study, but they would get cervical examinations and give blood samples, fill out surveys, but they also, for free, got the 3 shots of the HPV vaccine over the course of a year in the study. And then the 4th study was the one I led, and we developed and tested a multi-level intervention to increase the uptake of HPV vaccination in adolescents. So the multi-level was focusing on the parent, the child, the provider, and the health system. And we tested that in 6 counties that got the intervention, 6 counties that didn't.
Because ideally you want to start it at like roughly age 12, 14?
Well, at that time it was 11 to 12.
Okay.
But now you can give it as early as age 9.
Okay.
So
and the sooner you give it,
the better response. Okay. Your immune system will take it and incorporate the immunity that is given. Yes.
So what were the results of all these interventions?
Okay. So for Dr. Weghorst's study, he found that this genomic mutation, or SNP, whatever, TGF beta, was responsible for some cervical cancer, but in only a certain population. Dr. Wewers, as we alluded before, did find that the more smokers you have in your network, the more closely, you're likely to be a smoker. But she was asking the question then, could you use the social network to deliver an intervention? So possibly. We haven't moved on to that yet, but answered the question. Yes, social network is related to smoking. Dr. Ruffin found that, yes, the stress, your perceived stress, so we didn't measure perceived stress, is related to sort of the immune response you get to the HPV vaccine, but it won't negate it. It doesn't negate it.
So it's still effective,
Mm-hmm.
meaning you won't
still
get,
effective.
you can't get it.
Okay. You should still get the vaccine, right?
And you won't get cervical or head and neck cancer.
You'll reduce your
it
risk.
Reduces your risk, but not. Oh
Correct.
wow! So okay, so
you
stress
should
does
still-
stress does play a role, but it's still effective.
It's still
not
effective.
not as effective.
Correct. And we're now doing some additional analyses, looking at those data, which are kind of interesting. We're still working on them, and I hope to be able to have another paper looking at that actually. But it's kind of working out the way we thought, that where you live impacts sort of stress.
Yes.
That gets under your skin.
And there's a different stress than just being busy on the job than the stress of not having enough money for food and rent and the basics of life.
Right. There's good stress that makes us do our jobs but then there's the bad stress that gets under your skin. So more to come on that. And I will say that this connection between stress and health is really, really starting to, let's say, being the stone that's rolling down the hill, getting a lot more momentum. We have biological evidence now that it really does bad things. And it's not, we see it in many different cancers. I've been working with Dr. A.K. Eisfeld, trying to explain, why do you see poor outcomes in young, mostly black patients from, AML, a type of leukemia? Why? And we think part of it is stress. We do. So anyway, more to come on this stress, but I'm giving you a peek into kind of hot, cool new areas of investigation.
Okay, that was fascinating. And we're going to take a quick break. And when we come back, we're going to hear more about some of your amazing work.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with Electra Paskett, an award-winning epidemiologist, and there was another project program of yours that you wanted to talk about before we get into kind of what you're working on next.
Right. So there was one more project in that center, and that was Project 4 that I mentioned, increasing the uptake of HPV vaccine. So that was successful. So then we took that project, and we proposed a very large grant. They're called program project grants. There's those and another big grant called SPORES. You might have heard.
I've heard that
SPORES.
term, yeah.
Specialized Programs of Research Excellence. Those are kind of the jewels that They like to get. So we got a PO1, and what we wanted to do was address cervical cancer, but we worked across multiple states. So in the Appalachian regions, Ohio, Kentucky, West Virginia, and Virginia. And we were focusing on the 3 behaviors linked to cervical cancer: smoking, HPV vaccination, and screening. And so we implemented 3 different projects along those three areas in 10 health systems across the 4 states. So we were in 39 individual health clinics. And we're still analyzing the smoking cessation and the HPV vaccination results. The cervical screening, they've published their results. And what was kind of cool about this project was that, first of all, we worked with those health centers, and we found women at those health centers who needed cervical screening. And we had the clinics send out a letter to each of the women telling them they needed to come in. Then if the women didn't come in for screening within 6 months, then we selected a sample of women, and then we randomized, allocated the women to 2 different arms to receive a packet in the mail with a self-sampling kit, which I'll explain in just a minute,
Okay.
or just, usual care, a letter, you need to come in for your cervical screening. So self-sampling is something that's been around for several years. We did an early study on self-sampling. Will women self-sample cervical cells, return them, and can they do it, and are they as adequate as provider samples? And the answer is yes to both questions. So we did this large-scale test to see if women would
So women can
return.
swab themselves, put it in a tube, mail it.
Yeah.
Okay.
So they insert a special swab, much like a tampon, circle around, and then put it in a case, and then return the mailer. So the paper was published. Dr. Katz and Dr. Reiter led that study, and that paper was published, and yes, women will do it. But, the big but for self-screening at home is that if there's abnormal cells detected, you have to come in.
Right.
And that's always the bugaboo is that for any screening test, and we talked about this at the beginning of the podcast when we talked about it for colon cancer, that if there's a positive test, we talked about it for mammography, if there's a positive test, you have to come back for further follow-up, because you're never going to detect cancer early or precancerous lesions and get both treated if you don't go back for follow-up. So that's a huge issue, and it's a huge issue in this country. Virtually no health system has a setup to know who had a positive screen and who did they come back.
Oh, because the test results go directly to the women and the
They
medical
go to
people?
they go to the providers.
Oh, okay. So what's the hang up?
Yeah. What's the hang up? Why don't you have a system?
Of calling the women and making them come in.
But you need to have like a list. It used to be, this is what I did my doctoral dissertation on. Follow-up of a positive Pap test.
Oh, okay.
And the clinic told me that used to be they had a sheet and they would write down, Mrs. Jones had a Pap test, positive, and what was done to make sure she came back. And then, funding crisis hit. They didn't have enough staff or resources to keep doing that. And so nationally, it's still about 40% of women with positive Pap smears that don't come back. For mammograms, it's 30-something% of women with positive mammograms don't come back. For positive colon screening tests, it's anywhere from, could be 38% to 52% of those with positive screening on colon, the stool tests or the FIT tests that don't come back. Yes. So that's why you need a navigator, because the navigator will help people come back.
But that's why you need you to set up a program that has the funds to create a navigator and a system to do it.
Exactly.
'Cause it's not going to happen on its own.
So that was successful for self-sampling. And I believe it was last week, the American Cancer Society and several other guideline-based bodies approve self-sampling as a way to screen for cervical cancer now. Big thing came out yesterday. I got it, and a paper was just published saying that women should be able to self-screen in their own homes and return it to the doctor, and only need to come in for an exam if it's positive. So I think this is great because a lot of women don't feel comfortable coming into the doctor for the cervical screen, but they can now do it at home. But they're going to have to set up systems. Health centers have to set up systems, and I'm not only talking about, the breast, cervical, colon, lung screening, cholesterol, diabetes, elevated sugars. Are we keeping track of all these elevated results and getting people back in when they need to be?
So you and these programs show the way forward, but making sure that it's done properly on a national level is the challenge.
Right. So this leads me to another study we did, which was we were part of the Biden Moonshot Initiative for colon cancer screening. It's called Accelerating Colorectal Cancer Screening and Follow-Up. Did you see that? And Follow-Up.
And follow-up.
Through implementation science. So we were one of 9 centers on this. And we partnered with Kentucky, and we were in 6 counties in Kentucky, 6 counties in Ohio, Appalachia, all again in Appalachia. And one of the first clinics we went to, very small, I love this clinic, love it. Quaker City, Ohio. Any of you go to Quaker City, when you go off the freeway, you have no cell service the whole time you're there. Love this clinic. The staff are 100% dedicated to their patients. And they told us, we have 10 minutes to spend with our patients. How can we tell them what colon cancer is, what screening is, and describe the 3 different types of colon cancer screening, and then decide? We don't have the time. So we worked with them to implement an evidence-based, meaning there was evidence from scientific study that this intervention works. Okay, we implemented a fit test. So you mentioned the stool-based. Well, there's the stool-based test, but looks for markers of colon cancer that we talked about earlier. So there's an evidence-based protocol that we help them adapt for their circumstances and implement. And we help them modify it over the years, and they were able to increase colon cancer screening in that tiny little clinic. In fact, one day, they called my program director on Friday afternoon, and they said, we got this person to do the fit, after a lot of, we trained them how to be navigators. So we navigated them, to do the fit. The fit came back positive, and because we told them they have to set up the system to trace positives, they knew it was a positive. They navigated them to a colonoscopy, and they said, he had 10 polyps removed, and they knew that removing the polyps prevented a cancer.
So 10 pre-cancer
10
polyps
pre-cancer.
That would have over
Correct.
time become
Correct.
serious.
Correct. And they knew they had prevented a cancer in that patient. And that's what they want to do. That's what they want to do for their patients and their community.
So that was a good day when you got that
That
call.
was a good day
That's
when we
like
got that
everything you work for,
Yeah.
this is the reward.
Yeah. So when you asked me what's next, we're now working sort of on Access 2.0, so the next iteration. And we're working with folks in Massachusetts and North Carolina to submit another big grant. And we'll be focusing on people who have never screened for colon, people who have screened before, but they need to get another one, because you never one and done. You always have to keep getting the regular screenings for whatever cancer. And then follow-up of abnormals, as I mentioned, that's a problem. So that's what we'll be working on is our next iteration. So the other thing I wanted to mention is we did a study with Indiana University, Dr. Vicki Champion, and her expertise. She also has been doing cancer screening improving cancer screening for years. Her expertise was using DVDs and or programs on computers to help people make choices.
So they can watch videos and learn?
Yeah. And so we combined, and we got a grant from the National Cancer Institute several years ago. And she adapted her interventions, which had been for the Black African American community in Indianapolis, to working in rural counties, which was our expertise. And we have expertise in patient navigation. So we combined our efforts, and we tested 2 remotely delivered interventions for women who lived in rural counties. So we enrolled almost 1,000 women, and we recruited from every rural county in Indiana and Ohio. That is 98 rural counties. We recruited using Facebook, and then women either were allocated to a usual care arm where we sent them newsletters about health, or the arm where they got this tailored DVD, which I'll explain just half a second what that is. Or in addition to the DVD, they got a phone call from my navigator. Okay. And the whole goal of the study was we wanted to get the women up to date with breast, colon, and cervical cancer screening. Never before had there been a study that focused on 3 behaviors at the same time. And so women who we recruited, they could need only one of those exams. They could need only 2, whichever 2, or they could need all 3. So there were 7 different combinations that women could need. So what the DVD did, and you might say, Electra, why did you do a DVD? Because we found that in a lot of those areas, there's a digital divide. Remember I talked to you about Quaker City, right? So digital divide.
They don't have laptops. And
correct. Or they still do dial-up, right? Or they don't have laptops. They don't have the equipment, or they don't have the broadband, right? But virtually everybody had access to a DVD somewhere. Either they had it, or their family did, or they could go to the library and access DVD. In fact, we would mail people DVDs if they didn't have one, but we really only came up with one person.
DVD players.
DVD players, sorry. Yes, thank you. And we only came up with one woman who didn't have one, but she said she could go to the library to use it. Right, okay. So they would put the DVD in, and they could use the clicker to answer the questions that came on the screen. What test did you need? And then it had a video embedded in it that really nice. Talked about, we had a narrator, a woman physician narrating, talked about what cancer is, what breast cancer is, and then described the tests, and then went through questions as to what are your barriers? And then when they'd answer what the barrier was, we had then vignettes that would come in where we had recorded stories of cancer survivors that told. So one woman was a colon cancer survivor, and she said, I was really reluctant to ask anybody for a ride to get my colonoscopies, but then when I asked, people were more than willing to take me. So just, things like that could alleviate people's worries. But it also was presented somebody that looked like them, rural women, spoke like them, so that they felt comfortable. So then the navigator, the women who were assigned to get a navigator in addition to DVD, would call the women like 10 days after the DVD was mailed and said, did you get the DVD? Did you watch it? Do you have any questions? And be able to facilitate. Yeah.
So this is amazing. As you're talking about this, I always sort of look at the bigger picture. So between the programs for colorectal cancer, breast cancer, and cervical cancer, these are cancers that you can either prevent or detect in their earliest stages when it's like 90 to 95% cure rate. You can save thousands of women from getting cancer and dying of cancer. Which is kind of amazing.
Correct. So I want to tell you the result of the study. So we found that the women who were in the arm that got both the navigation call and the DVD, 5.6 times more likely to become up to date with all 3 screening tests.
Wow.
Compared to the usual care arm. Yeah. So it worked. And I want to tell you one story. Can I tell you one
Of course.
story? So unsolicited, I get an email from a woman. Now, you say, well, how did she get to you? They all did a consent, and my name's
On it.
right? And if you have a question, she said, I just want to thank you for saving my life. So I get the story. This woman is overweight, obese, feels very self-conscious with her doctor. She felt like the doctor judged her, didn't feel comfortable getting a cervical screening from the doctor. The woman was assigned to the Navigator plus DVD arm. So the Navigator said, now, first of all, sorry to interject this, but you see why it's so important to have a Navigator?
Yeah.
And the Navigator is a woman from the rural area.
Oh, okay. That makes sense.
Sounds like the woman.
Yeah.
The woman could say this to her. She said, I don't feel comfortable. So the Navigator said, what if I found you a female physician close to your house, takes your insurance, still taking patients? Would you go? Yes. She did all that. The woman went. And when she had her cervical sampling, they got some, it's called endocervical cells, so the cells between the endometrium and the cervix, and noticed some abnormality. And so she had pre-endometrial cancer that she went in and it was treated, and if left untreated, she could have had endometrial cancer. And she said, you saved my life.
Wow. I usually like to ask people at the end what motivates you to do what you do, but I think you just answered that.
Well, you know also what motivates me. I'm a 3-time breast
Right.
cancer survivor.
Yes.
My mother had 4 cancers. My father died of colon cancer. So my motivation is I do what I do so other people don't have to hear those 3 words, you have cancer. Anyway, so we're taking this study that we did in the rural counties, and we're going to adapt those interventions and implement it in an urban setting. So we're now doing that here in Columbus in federally qualified health centers. And again, focusing on 3 cancers.
So, again, I'm guessing that it's going to be effective. What happens next? How do you then get the whole country to do that?
Yeah, that's a good question. So, I'm on several national boards. I mentioned at the beginning that I work on the American Cancer Society National Roundtables. So I'm on the cervical roundtable, the breast cancer roundtable, a little more tangentially, but also the navigation roundtable. So we've talked about navigation. We were part of the original study called the Patient Navigation Research Program, which validated patient navigation. And as part of my work on the Patient Navigation Roundtable with the American Cancer Society, we worked with the Biden administration and were able to get patient navigation as a covered benefit under CMS and get it really to take shape nationally, so that now there are many navigators across the country. So that's sort of how
doing
my
great
work goes.
Doing great work and encouraging others to do it.
Yes.
Is how you slowly.
Yes, and teaching others how to do it.
Science is never quick, but you're determined.
Exactly. Yeah.
Well, thank you. It's always amazing and a bit inspiring to talk to you. So just keep up that great work, and I'm sure new programs are going to come about and maybe even new awards over the next few years. So thanks for filling us in.
All right. Thanks so much for having me and for your great work, Steve.
Oh, thank you. This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.